Okay, Assalamualaikum everybody. Good night. We are actually in the second CME for chest X-ray interpretation to be delivered by Dr. Kay. Thank you, Dr. Kay, for your time and dedication. So we value and respect your enthusiasm in teaching. Without further ado, I would like to invite Dr. Kay. But before that, I would like to remind everybody for this session, we have CPD points available. So this is done via Google Link, which will be available in Zoom chat. So for those of you who want CPD points, you have to participate in the Zoom meeting itself. This is not available via Facebook Live. So for those of you who want CPD points, please enter Zoom meeting and the link will be available in the Zoom chat. Thank you. So Dr. Kay, are you ready?
Yeah, all good.
Okay, so I'll pass the floor to you and you can share your screen for the slides, okay?
Can you guys see it?
Yes.
Okay, Assalamualaikum and a very good evening, everyone. So today we'll be talking about chest X-ray. The other day I already talked about chest X-ray, but those are actually the basics. So this time around, I'll be more focusing on the mediastinum and also some parts of the pleura. Why is chest X-ray important? You see, in my hospital itself, within the past 7 days, we have done 1,272 X-rays, out of which 515, which is nearly 41% of the X-ray are only our chest X-ray itself. So that's a big number considering the rest of the body is like ada banyak tempat kan, ada tangan, kaki, muka. But 41% is chest X-ray. And I have also seen, because I just did my presentation like about 6-8 weeks ago, there's a leap in 300 X-rays within 1 week, which is actually quite a bit of a burden to us. But what I'm trying to say is that X-ray is becoming increasingly used, especially in this COVID era, and those are normally chest X-rays lah. So this is my outline. We'll be talking a bit on the lungs, but this is I'm just going to like fly through because we already talked about the lungs like in depth the other day. And then we have the mediastinum, which is the bulk of my talk, and also some about the pleura. So we'll just go fast to the image technical evaluation of chest X-ray. If you still remember, this is the epitome of a good chest X-ray, in which if you see this kind of chest X-ray, you'll be more confident to interpret the chest X-ray because it is perfect. So we must be able to see the 6 anterior costal arches so that the patient is well, they aspire well, and the symmetrical procreation of the thorax and good vascular pattern of the lung to tell that the patient has good penetration of the rays, and also it is of suitable density. We can see the retrocardiac lung and mediastinum as well, and also the sharpness and suitably collimated. Collimate means it's suitably dipotong lah, meaning it doesn't cut unnecessarily big or small. And this is just a fast recap. In an X-ray, whenever you see that it's too white, then we're looking at something that might be metallic, and if it's too black, there is usually air. So we have to understand this gradient of changes from metal all the way to air for us to understand the what we are seeing in the chest X-ray. And because chest X-ray is actually a 2D representation of the whole thorax, which has a lot of structures, so we are heavily relying on the different densities for us to understand the chest X-rays itself. So I'll just fly through the lungs. I'm not going to talk much about it. So whenever we talk about lung diseases in chest X-ray, we were talking about alveolar diseases, which is the one that is the S spaces. Whenever that the S space is normal, it is filled with air. So you can see black, so like this is the black part. And whenever that it is filled with something, like when you see something feeling whitish color, it means that it has some form of fluid, pus, blood, or protein. And interstitium is the one outside, which is the one supporting the unit, the alveolar unit. So we can divide them into alveolar changes or interstitial changes. which is like average changes usually comes like a cloud-like fluffy, ill-defined margins, and sometimes it can coalesce together to eventually become a consolidation. And the interstitial ones, usually they are nodular, reticular. Reticular means straight lines, or reticular nodular. So it depends what we're looking at. So just fly through again. So we have a consolidation. We can have masses or nodules, interstitial changes, or atelectasis. Atelectasis means that it is some form of collapse. It could be a whole collapse or it could be a partial collapse. So consolidation depends. We can have different type of contents such as water, pus, blood, and also cells. So the pattern of consolidation can be diffuse, lobar, multiple, ill-defined. You can also have the back wing or the reverse back wing kind of appearance, in which each of these changes can help us try to narrow down the causes of the consolidation. It might not be foolproof, but it could be helpful. And atelectasis happens because of either resorption or the relaxation by the resorption, such as the mucus, tumor, and foreign body, causing the lungs to not be aerated, and eventually it gets resorbed, or there's something outside pushing it, causing it to collapse. And nodules and masses. Nodules is when something is less, the bulat is less than 3 centimeters, and mass is especially when it's more than 3 centimeters. And if you have multiple masses, these are the kind of differentials that need to come in mind. So the interstitial, as we said, is the one outside the unit, the alveolar unit. So we can have the reticular, which is the straight line types. Again, they can have the smooth septal, irregular septal, honeycombing, and this is actually more or less seen in the HRCT. We are unable to see this kind of changes so nicely in the chest X-ray, but we can actually see at least it's nodular or reticular, or it's reticulonodular. So we can decide when we see those, we can move on to HRCT so that we can narrow down whether it is a smooth septal type, which is such as a lymphangitis, carcinoma kind of thing, or they have honeycombings because of UIP. So whenever we see those lines or nodules that we are so unsure about, we can always do HRCT as our next step. Okay, so moving on to the mediastinum. There are a few ways for us to divide the mediastinum. Some people divide it into 4, which is superior, anterior, medial, and posterior. So in the first place, what is the mediastinum? Mediastinum is a region in the chest between the pleural cavities, which contains the heart and the thoracic structures, the viscera, except for the lung. So some people divide it into the superior, anterior, medium, middle, posterior, but I'm going to divide it into anterior, middle, and posterior because I learned it that way. So what is the anterior mediastinum? So this, the blue color one, is the anterior mediastinum. So everything that is forward and superior to the heart. So the yellow thing is this heart, and everything superior to it is superior and forward, meaning depan. The heart is considered as the anterior mediastinum. So it is bounded by the sternum, the first rib, and then the anterior heart border. This is just an imaginary line. You anggap je lah ada. And then the brachiocephalic vessels up here, and then the diaphragm all the way to the thoracic inlet. So the diaphragm, I mean here, all the way to the thoracic inlet. So this is our anterior mediastinum. So usually in the anterior mediastinum, we have the thymus, the thyroid, the glands, and we usually, if we see there's an anterior mediastinum punya masses, we give 4 general differentials, which is the 40, which is the thyroid, thymoma, terrible lymphoma, and the, okay, I forgot the 40. So moving on, this is the middle mediastinum, the one yellow color. So the middle mediastinum is dorsal to the anterior mediastinum, belakang anterior mediastinum. It is from the lower edge of the sternum here, along the diaphragm, and then carefully at the posterior wall of the trachea. So this middle yellow part is our middle mediastinum. So it has the heart, pericardium, the aortic arch, and the major branches. All this is mostly the heart, pericardium, and the vessels, the big vessels. And we have trachea and also lymph nodes and the phrenic and upper vagus nerve. And we move on to the posterior mediastinum. It is the one at the back, the red one. So it's behind the heart and in front of the vertebra to make it easier. And it has the esophagus, the descending aorta, the big vessels again, the thoracic duct, and some sympathetic chain as well. So again, this is what do you call that? Condensation of whatever I just said just now. And these are the main structures within the different mediastinal punya compartments lah. So this is the mediastinal contour. Whatever it is, for you to understand abnormal, you must first understand normal. So we must have in mind what normal looks like. So we need to see the diaphragm. I already touched on the diaphragm the other day, in which that the diaphragm on the right is always higher than the diaphragm on the left, in which they usually have a 2 centimeter gap. And if it's more than that, you have to think of something. And this is the right atrium, the ascending aorta, this one, superior vena cava. And this is the innominate vein, aortic arch. This is the AP window. And then the left ventricle, descending aorta is the one behind here, and also the diaphragm. So as we go along, I will keep showing some of the nila. So this is the, what do you call that, summary of what kind of lesions you may find in each of the mediastinal compartments. Bear in mind that some pathologies can actually have, what do you call that, an involvement of more than one compartment. So those are to be kept in mind because sometimes they have overlapping kind of features. And the type of lesions that could be there can be also divided into lesions, which is, what do you call that, solid lesions, fluid lesions, fat, and also vascular lesions. So this is just an overview. I'm not going to talk about each and every one of them. I'm going to show this image over and over again throughout this presentation because that's how important it is. So these are the lines whenever you see a chest X-ray, these are the reflections that should be there. These are the ones that constitutes normal. So we have the yellow posterior junctional line, and then we have the left and right paratracheal stripes and the anterior junctional line, the zygoesophageal recess, the paraspinal stripes, the aortic line, and also the AP window and the AP stripe. So this is normal. Bear in mind that you need to have these lines for you to see normal. So mediastinal mass, unlike lung lesions, they do not have air bronchograms. So if you find a mass with air bronchograms, it most likely, it must be from the lungs, because it means that the lung has consolidated, but still there are airways from the bronchus all passing through. And the margin will be obtuse. I'll show you later what it means. And the mediastinal lines will be destructed, like the one I showed just now. These are called mediastinal lines. And they can be associated spinal, costal, or sternal abnormalities, so in which we have to have a look at it to see if there are any adjacent bone erosion. So like this is the tapered margin sign, in which whenever it comes from the mediastinum, you see the angle between the mediastinum ni dia macam obtuse tau, obtuse. Kalau parenchymal lesion, usually it will be acute angle. So this one is the acute angle with the mediastinum. So it probably is a pancreas tumor coming from the lung. Tapi macam this one, it's actually obtuse, this angle. Okay. So this is just another condensation in which how anterior mediastinal, medial mediastinal, or posterior mediastinal lesion will come about. I will keep talking about it here and there. So these are some of the ways for us to differentiate whether this lesion, these masses are coming from the anterior, middle, or posterior. Like the anterior mediastinal mass, it lies adjacent to the heart, it may efface the heart border. And then the middle mediastinal ones may efface the carina or efface a normal hilar shadow. We'll see as we go on. And the posterior mediastinal may either displace one or both paravertebral stripes. And it can also destroy a vertebra or a rib. So the other day I already talked about the silhouette sign. What does the silhouette sign mean? Silhouette sign is actually whenever you have a structure interfacing each other, macam macam ada vessel and then there's a lung. So in between the vessel and the lung interface tu, there's a macam this vessel is like that and the lung is like that. So in this interface, we'll be able to see something that is white, meaning the lung is black and this one is white and it cuts. But when you lose it, when you lose that silhouette yang sepatutnya ada, that's a silhouette sign, meaning that you lose something that is the line, the normal lines. Terbalik sebenarnya. So macam this one kan, you're supposed to have a an aortic knot kat sini, but then there's a mass over here obliterating. So the silhouette of the aortic knot tu is indistinct. That's what it means. So macam pulmonary artery overlay sign, you're supposed to have the pulmonary artery here. Same concept lah. If you'll be able to see a pulmonary artery in clarity, it means that it is either in front or behind. It is not on the pulmonary artery itself. So it could be an anterior or posterior mediastinal mass. And this one is a Highland overlay sign. This is the Highland point that I taught the other day, if anyone still remembers. This is the Highland point yang V shape ni. So if you see the hilum through the mass, it could also mean that the mass is either from the anterior mediastinum or the posterior mediastinum, because the hilum is in the middle. So dia tak kacau hilum tu. So the hilum is supposed to still be seen. But because it is there, it interfaces. Boleh faham tak? I hope so. So anterior mediastinal lesion, usually it will cause obliteration of the anterior junctional line. So it could have abnormal AP stripe, preservation of the posterior mediastinal line, silhouette sign with the right cardiac border, and the hilum overlay sign, like I mentioned just now, and obliteration of cardiophrenic angles. So these again are the anterior mediastinal masses causes. So we're talking about the anterior junctional line. So this is the anterior junctional line over here. What is actually an anterior junctional line? It is actually from the this. Can you see this? Yes, this is the anterior junctional line. When seen in CT scan, it is actually this reflection of the four pleura meeting anteriorly in the middle. So that's that is how it looks like in CT. And when you translate it to chest X-ray, this is how it's been seen lah. So like in this case, you don't see anymore the anterior junctional line, but you still see the hilum overlay sign at here, macam the V shape thingy tu. So it shows that it's not in the posterior mediastinum. It should be, I mean, it's not in the middle mediastinum. It's anterior or posterior. But since there's also a loss in the anterior junctional line, so it means that it is anterior. So when we see in the CT scan, it is situated in the anterior mediastinum. This case is a lymphoma case lah. So contoh middle mediastinal lesion, we can have widening of the paratracheal stripe with distortion of the zygoesophageal recess and the convex border of the epineural refraction. I'll show you. And these are the types of middle mediastinal masses that we can see, such as the lymph nodes, arch anomalies. And this is what we mean by the right and left paratracheal stripes. These are the paratracheal stripes, the red color things. The paratracheal stripes, what constitutes it? So when we see here, this straight line here, it's actually when you have there's two parts tau, there's satu kat sini, satu kat sini. So these are the two different cuts in the CT scan to, what do you call it? To menerangkan. To menerangkan lah why it occurs. So one is because the CT scan, you see this tracheal wall, the end of the tracheal wall, and then there's a soft tissue interface with this vessel over here. So that causes this white thingy. And lower down, there's an interface between the tracheal wall itself and also the azygous arch. So this is the, if you find that it is more than 5 mm, this stripe, then it is abnormal, such as this. So this is obviously more than 5 mm. This is our trachea just now kan. You see that the trachea is pushed aside and the right paratracheal stripe is more than 5 mm obviously. So in this case, it's actually a right-sided retrosternal goiter when we see it in the CT scan. And then this one, again, the right paratracheal stripe is very much widened, this whole thing. This is again a lymphadenopathy when you see in the CT scan. Next, I'm going to show you is the AP window. The AP window is this. You see this lekuk over here? Yeah, that's the AP window because it's aortopulmonary window. It's in between the aorta and the pulmonary window. So this is the aorta and this is the pulmonary window. So this is what you call the AP window lah, in between. Okay. And abnormalities in AP window, usually we see lymphadenopathies lah. You see apa just now? This is the aortic knob tadi kan, and this is the, we're supposed to have the convexity over here, but it is lost. And when we see in the CT scan, it is there's a mass over here, and usually and this particular image is a lymphadenopathy. And this one pula, we see another aortic AP window obliteration, and this is caused by aneurysm of the aortic arch. So the aortic arch is going up, and suddenly there's an aneurysm over here. So the usual interface with the lung is lost. So there's another density added to that, so we can see this kind of look. The thing is, in medial mediastinum, there are a few variety of normal vascular variants which we can think that it might be what do you call that, medial mediastinal disease, but it's okay. Contohnya lah, we can have a right-sided aortic arch. So this right-sided aortic arch demonstrates this right paratracheal region punya what do you call that? Right paratracheal region thickening, widening. And then when we do the CT scan, it's actually a right-sided aortic arch instead of your usual left-sided. You see that? And then we can also have a left-sided SVC. Usually our SVC is here kan? Macam mana tu ada terpindah kat sini. And if you see this, this is a fluoroscopic image of the great vessels, and the SVC is draining on the left side instead. And then next we go to the zygoesophageal recess, which is this line over here. This one, you see that? Okay, the zygoesophageal recess ni, the CT scan shows this part of the zygoesophageal recess. It means that this white arrow over here, that is the recess. It is formed by the esophagus, this esophagus, and also the esophagus. This is the zygoesophageal recess. Okay, sorry, sometimes I can get confused myself. From the esophagus anteriorly, and then also we can have the and also the azygous vein lah. This is the azygous vein. This is the esophagus. So we have the line in between because the esophagus kat sini and the azygous kat sini. So zygoesophageal recess. Okay, don't feel bad. And then we can also have this like this one is a image of a bronchogenic cyst. Our usual zygoesophageal recess is already obliterated in this case. So we can see that the bronchogenic cyst is playing the it's a subcarinal mass, and it's also splaying the carina over here. So this is a bronchogenic cyst. And posterior mediastinal lesions can be seen as thickening or distortion or destruction of the paraspinal lines. And it can also cause abnormal contour of the parietic line and obliteration of the posterior junctional line. And distortion of the zygoesophageal line because it's at the back, and also the cervicothoracic sign, but I'm not talking about the cervicothoracic sign. So these are the lesions that could be found in the posterior mediastinum, and most commonly the posterior mediastinal lesions or masses are almost invariably comes from the bone vertebra or something that is neurogenic. And if we have more than one compartment, macam contohnya middle plus posterior or anterior plus middle or anterior going all the way to posterior, it could also be one of these such as infection, hemorrhage, cancer, hemangioma, liposarc. So we'll be talking about this posterior junctional line. This posterior junctional line is like, and just like anterior junctional line, it is actually a reflection of the four pleura when they meet together in the midline posteriorly. So this is what we see in the CT scan, and this is how it is interpreted in our chest X-ray. So like in this case, the posterior junction line is obliterated. There's a mass over there. Do you see that? And it's a well demarcated outline. And then when you see the CT scan, it is confirmed to be in the posterior mediastinal location. In this case, this is a bronchogenic cyst as well. And then we have the right and left paraspinal stripe, which is the green color thingy here. Okay. Okay. So this is the normal paraspinal line. This normal paraspinal line is separate and distinct. This is our name. This is our descending thoracic aorta. You see this one? This is our normal descending thoracic aorta. So we have something slightly to the lateral, and this is our paraspinal line. So this is how it is seen in the X-ray. In the CT scan to translate back to this X-ray. So this is the normal line. But whenever the line is not, if you see here, suddenly dia jadi gemuk macam tu. Padahal this is our usual aorta. How come it jadi gemuk like that? So in cases like this, usually you have to be very wary because most of the time this retrocardiac region is the place that you miss looking. You remember I taught you last time that we have a few places that we must remember to look at, which is our review areas, which is the apexis, the diaphragm, the CP angle, and also here. So this one, if you don't see it, you might miss it. So in this case, it's actually a paraspinal abscess, usually from TB and things like that lah. And then this one pula, is a descending thoracic aneurysm. This is the descending aorta. This is the aortic knot. Main turun bawah, tiba macam tu. So the CT scan also demonstrates the aneurysm. And in this case, nampak tak? This one is the descending aorta, and suddenly you find it. This is not supposed to be there. It's just supposed to be like one line nicely turun bawah like that. And when you do the MRI in the coronary formatted, we can see that there's a left paraspinal mass. In this case, it's a neurogenic tumor. Okay, so we're done with masses. We'll just go to pneumomediastinum for a bit. In children, pneumomediastinum can give what you call a angel wing appearance because of the thymus is pushed up during the when there's a air, the air pushes the thymus up, so it gives this pneumomediastinum angel wing appearance. And this one is called the continuous diaphragm sign. What pneumomediastinum means is that they have extraluminal gas within the mediastinum. It can be because from the lungs, from the trachea, or the central bronchi, or even the esophagus, or the peritoneal cavity that can creep up and cause a pneumomediastinum. So this one is continuous diaphragm sign. And you can also see like this. This is if you don't see if you don't scrutinize, you might just miss it. You can see that there's air in the paratracheal stripe, and then air outlining the left mediastinum, and then outlining the esophageal recess. If you happen to find any cases with trauma, especially with subcutaneous emphysema, among the things you should remember finding is the pneumomediastinum as well. And this is pneumopericardium. How do we differentiate pneumopericardium with pneumomediastinum? In which the air is lining the heart, but it doesn't extend beyond the great vessels. So this is pneumopericardium. Okay, now we go on to the pleura. So there are a few pleural pathologies that we know, but I'm not going to talk about everything. So we have the pleural effusion, pneumothorax. I'm not going to talk about the bronchopleural fistula because it's very hard for us to see bronchopleural fistula in X-ray. Usually we think about it clinically, whereby the patient has pneumothorax, and the pneumothorax is not reducing even after chest tube. So that's a telltale sign that it might be. And CT scan is needed for bronchopleural fistula punya diagnosis. And we have pleural thickening, calcification, and also tumors. So pleural effusion happens when there is pleural fluid produced, or there's diminished resorption, or they have both in concurrence. So the commonest appearance of a pleural effusion is you have this called meniscus sign. Ada macam tu. You need at least 200 to 300 ml of fluid before you can even see blunting of the diaphragm. Of the CP angle. So like this one, actually is a large effusion lah by now. Mesti dah berliter dah. If it's totally wiped out, then the effusion is, we will say massive effusion ataupun wiped out lung. So actually there are a few types of pleural effusion. We have the Lamellar type, in which is a linear shadow paralleling the lateral aspects of the lung. Dia just sangkut kat sini je. And this one usually happens in children or patients with heart diseases lah. You see this one? This is a bilateral lamellated pleural effusion. And you have the loculated type. The loculated type means that it is encysted. So the fluid is collected between the two layers of the pleural lining in the horizontal feature. It can be round or oval, and sometimes we think that it might be a tumor. So macam this one. So it looks like a tumor, tapi bila kita buat CT scan semua tu actually is not. It's just loculated pleural fluid. And we can also have the subpulmonary type. The subpulmonary type ada it's actually the pooling of the pleural space below the lung. So there's two lah, the right side and the left side, and each of them give different appearance. So if you see the diaphragm on the right side, tiba-tiba dia punya highest point is too lateral, so you must keep in mind that there must be some form of subpulmonary effusion. Because usually kan your dome of diaphragm kan dia quite centrally kan, tapi this one dia punya peak tu dah too lateral, so you must keep in mind that there might be a subpulmonary effusion on the right. On the left pula, you have similar appearance. Dia punya apex sudah too lateral, but you can also see that the gastric bubble tu macam push down, so it's widely separated from the margin of the diaphragm. Otherwise kan dia dekat je. This is a real contoh lah. So this is the right-sided subpulmonary effusion. Macam ni goes on the. This is the normal. If you compare, there's a huge gap over here. So that might be a left-sided subpulmonary effusion. But in this is a normal finding of a diaphragm stomach bubble interface. And this is a high hemidiaphragm in subpulmonary effusion. Remember I told you that the hemidiaphragm could not be more than 2 centimeters different. If it's more, then we might have to think of what is the cause. Is it the right-sided problem or left-sided problem? In this case, it's the right-sided subpulmonary effusion lah. And this is a CT scan showing that there's a pleural effusion with pleural thickening itself. So pleural thickening with enhancement could also mean that the patient might have empyema. And this is a pneumothorax. Actually, we in radiology, we never really say whether the pneumothorax is a big pneumothorax or small pneumothorax. We know that it's big or small, but we never really, ukur lah. But in ED, they usually do. So I found out that actually if it's less than 2 centimeters, we call it small, and if it's 2, it's large, because we never really ukur kan. We just say, oh, there's a gross pneumothorax. Tapi actually, I just knew myself that actually we boleh ukur. So it's taken from the margin, from the rim of the pneumothorax to the chest wall. And this is a huge pneumothorax. As you can see that the lung markings are all disappeared, and the lung is collapsed to this one side. So we have 2 types of pneumothorax, which is the tension versus the non-tension. How do you differentiate them? So the tension pneumothorax ni, you can see that the lung is collapsed with the pressed hemidiaphragm, and there's mediastinal shift to the right. It means that this part of the lung, of the pleura ni dah push everything, and the pneumothorax in this case is you must decompress it almost right away. And a non-tension pneumothorax, you can see that the pleural edges is here, they collapse. Tapi you can still see the pleural edges and all. The mediastinum tu tak usik, it's still in the midline, and the hemidiaphragms are not depressed, they are equal heights. Ataupun still within the 2 cm punya allowance lah. And in this case, when you see a pneumothorax, tapi tiba-tiba ada air fluid level inside, so it could be a hemopneumothorax or a pleural effusion plus pneumothorax, because there's air fluid level. It's not supposed to be any air fluid level if it's just a pneumothorax. And this is another contoh lah, pneumothorax with air fluid level. You see that ada air, tiba ada air fluid level kat sini. And this is pleural tumors, just to show you, ada malignant pleural tumor kat sini. In this case, this is a malignant mesothelioma, which causes the rib erosions as well because of the pressure erosions. Sometimes it eats into it. And this one is a pleural fibroma, in which 1/3 of it is malignant. Like just now I mentioned about obtuse angle kan, this is obtuse angle. Nampak dia besar angle dia. If it's from the lung, maybe dia akan bulat macam ni, then dia akan ada some acute angle. And this is just pleural calcifications lah. Pleural calcifications can be due to some old infections macam TB, some old trauma, pernah ada hemothorax, and then it resorbs and eventually becomes calcified, or some form of pneumoconiosis or hypercalcemia that deposits into the pleura. So how do you differentiate whether it's pleura or extrapleural ataupun pulmonary regions? So in a pulmonary region, abutting a pleural surface like this is actually from the lung. Tapi dia dekat sangat dengan dia punya pleural punya region ya. So how do we know it's actually from the lung? Number one, you see that the margins are clear. Semua margin dia clear, you can draw. And then the interface between the pleura here and the mass itself, it is acute angle. Meaning if you draw an angle from here and then you follow, it is acute angle. Acute angle, kalau ikut matematik kita belajar masa dulu, kurang pada 90 degrees. And then if you have an intrapleural mass, but it's indenting the lung, meaning it's actually from the pleura, tapi dia tolak masuk to the lung. So how do you know? So the margins can appear ill-defined. Especially dia macam not macam tadi kita nampak semua kan, ini kita nampak one part je, another part is about ill-defined, meaning that it's coming from somewhere outside. And then and it's the border ni only one side je defined, and it forms an obtuse angle with the pleura. So this is the pleural margin, this is the lung margin. So this is more than 90 degrees. You see that? Kalau kita draw macam ni. And another one is extrapleural, tapi intruding on or into the lung. So this is actually it's from outside, tapi dia masuk. So dalam these cases, usually it's from almost always an abnormal rib. So maybe there's a metastasis ke, or some form of rib infection ke, eventually it's in and it's out. So macam in this case, you don't see the margin of the ribs betul-betul dah. Maybe it has been eaten up by the mass itself. So I have come to the end of it. Actually, my take-home message is simple je. You need to understand normal before you understand abnormal. So this is the normal mediastinal, and this is normal chest X-ray, in which these are the mediastinal punya contours that you must see, and the lines that you must remember. If you see any of them not looking normal, actually you don't need to nipon, you don't need to make diagnosis out of it. You can always talk to us and we can help you out, and most of the time we cannot pinpoint it for you, so we will still offer you a CT scan anyway. So yeah, you need to understand the normal for you to be able to see what is abnormal. Okay, thank you very much. Do you have any questions?
Okay, thank you very much, Dr. Kay. Okay, very informative. Before we go to the audience question, I have a few questions. You said about the subpleural effusion before this. I just want to know if for this subpleural effusion, what is the next step of investigation? Shall we do the ultrasound domain or ultrasound pleural?
Ultrasound, ultrasound pleural. Actually,
Or no need?
you minta ultrasound thorax pun boleh juga.
Ultrasound thorax lah.
Ultrasound thorax.
Okay. So next one is regarding trap lung. For trap lung, sometimes we see there's a pleural effusion in the right lower zone, but we're not sure what is the causes lah. So when we tap, then we know. Bila tap dah keluar, baru kita tahu yang ada pneumothorax kat is pneumothorax ataupun ni lah. So is there any way how that we can detect it in X-ray lah for trap lung?
Okay, I have to ask you first. Trap lung tu benda I tak pernah guna.
Trap lung is macam apa? Is the lung is trapped to be expanded, macam PTB near the bronchus. So what it cause, it will compress the bronchus and makes the lung parenchyma to be collapsed lah.
Ini
so,
endobronchial TB ke?
It can be endobronchial PTB or it's a malignancy lah, lung malignancy.
From the outside.
From the outside that can collapse the ni lah, the bronchus lah.
Okay.
So what happen is pada masa yang sama the lymphatic drainage also akan obstructed. So the patient will have this effusion lah. We only gonna know about this trap lung bila kita tap actually effusion out already, but the lung cannot expand. This is what we call a trap lung lah. So then after that baru kita proceed with the CT thorax to make sure to see the ni lah, the airway punya obstruction. Baru notice actually there's a airway obstruction that causing the lung cannot be expanded. So kalau dari segi X-ray, is there any macam clues that we can see kalau case like this?
For endobronchial lesions kan, endobronchial lesion or lesions causing lesions from the outside causing a collapse. Remember the last time kita ada belajar pasal yang upper lobe collapse, middle lobe collapse, lower lobe collapse. So each of the collapse has different type of look. Tapi the thing is, if we see a collapse, we can just tell that it's collapsed. We cannot tell it's secondary to semestinya we can know the etiology. So if clinically you dah clear the outside, but you ingatkan the collapse because of the pleural effusion kan?
Yes.
Actually, and then, meaning the lung dah kena tolak pleural effusion, so you assume that the pleural effusion was the one that caused the collapse. And then bila you tap, you tengok, it's not expanding. Why? So that is also clinical. I think after you dah ni pun you tak nampak, it's very indicated for you to ask for a CT. I don't think it's wrong at all.
Okay, understand. Okay, thank you very much for answering my question. So we go for the our audience in Zoom. So hi doctor, my question is, what are we looking for in the lateral view of chest X-ray?
Just so you know, I don't use lateral view chest X-ray, and as I remembered during my 4 years of my training, and sekarang in total 6.5 years of me doing radiology, we don't use lateral as much anymore, or almost none. Myself, I have never read or even cadangkan lateral chest X-ray, because number one, it's really hard to baca, because when you have a frontal chest X-ray, you dah ada banyak interface kan, dah ada daripada kulit all the way sampai ke tulang belakang sana. And if you have a lateral chest X-ray, you are giving dia punya lapisan-lapisan tu lagi banyak for you to imagine. So it's a lot of imagination involved in interpreting a lateral chest X-ray. So if we see something in the AP chest X-ray or PA chest X-ray and we are certain that something is going on, we go for CT scans nowadays.
Okay, thank you. Okay, so the next question from Ahmad Iqmal. Sorry doctor, maybe I missed the explanation. I usually heard measurement widen mediastinum more than 8 cm. At which level we measure it? Or which line is it is referred to for measurement? Thank you in advance.
Okay, this one is actually you missed it because I talked about it in the last session. So a wider mediastinum tu we will take it at this level. You nampak I punya ni kan, I punya arrow kan Yes. You will take it at about this level, at the aortic aortic knob punya level ni, you take it there. I biasa ambil sebab kadang-kadang kan you ada PA, kadang-kadang you ada AP. So I biasa ambil about 9 to 10 tu, and then baru macam, and in a good inspiratory X-ray 8. Kalau the X-ray is very badly inspired. Semua tu I ambil 9 to 10 because I'm quite lenient like that. So I ambil 9 to 10. Macam contoh, some people nak minta tengok TAA, thoracic aneurysm. Tapi lepas tu that thoracic aneurysm, dia kata thoracic aneurysm. Tapi it's in an old patient, long standing hypertension. Lepas tu under inspired pula. Normally I cakap ambil good inspiratory X-ray dulu, we have a look. Because dah banyak kali dah I tertipu. Eventually dia tengok alah unfolding of the aorta just because of that long standing hypertension in the elderly patient yang tak ambil nafas betul-betul. So it's a rugi patient tu kena kena masuk kontras lah, nak kena datang semua. It's not hard for us to interpret. Kita nak interpret benda normal 10 minit pun siap, 5 minit pun boleh siap, tapi rugi in form of patient tu, kesian dia nak kena radiate, nak kena bagi ni cucuk tak pasal-pasal, kalau cucuk 3-4 kali, things like that lah.
So it's the best one is to get a proper inhale expiratory film, right?
Inspiratory film.
Yes, okay. So next question from Khairul Anam. Salam doctor, how about to see ground glass opacity from the chest X-ray? Do you have a
Okay, macam ni. Ground glass opacity sebenarnya is strictly used for these are according to the textbooks that I use. Strictly used for describing CTs. So tapi kalau dalam X-ray usually we call it macam like I showed you just now, fluffy or bubbly, ill-defined margin macam tu. So we normally call it either alveolar ataupun S-space kind of opacities ataupun interstitial kind of opacities. So ground glass tu we usually keep it for, in my case lah, in my preference, I keep it for HRCT punya description. If I want to use it on a chest X-ray, I will say fluffy or ill-defined patchy opacities, S-space opacities ataupun patchy consolidative changes. So the use of ground glass to me and to many of my colleagues pun, it is reserved for HRCT punya ni lah, CTs lah punya description.
Okay. Next question will be from Lukman Kamal. Lukman Kamal, any distinct features on chest X-ray that suggestive of COVID-19 infection?
Okay, I wanted to put some images for COVID-19 sebenarnya, tapi I tak sempat sebab my slide dah ada 100, so dapat lambat. But whatever it is, I noticed that there's a change in trend in the COVID-19 punya chest X-rays in comparison to last year. So when we first saw last year punya X-rays kan, patient come in happy, their chest X-rays is kind of happy juga, maksudnya dia tak teruk sangat. Dia ada macam this fluffy sikit-sikit sana sini, usually we'll find ada diffuse type atau patchy type. Diffuse type tu maknanya the whole lung tu kena atas bawah semua. Tapi dulu when we first started out with the COVID, we find that it is more peripherally placed and it is macam fluffy kind of look. Tapi nowadays I notice maybe it's sekali dengan kita punya development of happy hypoxia punya patients, we see that even the patient tu nampak macam not too bad. Tapi bila you tengok dia punya X-ray tu, dia dah macam sangat comot. Dia macam sangat, apa perkataan yang sesuai, dia macam macam tu. This is my pengalaman seeing the changes that we see in the patients of COVID nowadays, when once upon a time kita nampak it's just patchy kadang-kadang you really have to strain your eyes. Nowadays you don't have to strain your eyes. You buka aja, it's staring at you. And banyak kali nowadays we see diffuse type. Maybe because now I'm in hospital, only category 4 kan, category 3, 4 yang baru naik taraf masuk ke hospital. Tapi dulu category 1, category 2 pun dah boleh masuk hospital juga kan. Sekarang category 2 dah duduk ke hospital yang belakang-belakang sikit.
PKRC lah kira ni.
PKRC. So maybe that's also one of the reason why. But you still have to understand my new patient tu, bila you tengok macam not too bad bila dia datang tu. Tapi bila you tengok X-ray dia, it is quite bad macam tu lah. So that's why I think that the patients nowadays they deteriorate so fast because sebenarnya dia punya changes of the chest X-ray tu dah teruk dulu.
Yes.
So ini I punya pengalaman lah yang tak seberapa.
Itulah, I also thinking that whether the PKRC punya Cat 1, Cat 2, whether need to be do X-ray first before we send them there lah. There's another thing lah, no? Because now the variant is quite aggressive compared to the previous one kan.
Dulu we have to really tengok betul ada kot some form of patchy tapi nowadays you buka terus macam I have to report this macam tu.
Okay. The last question will be from Apip lah. Hi doctor, how to differentiate between air under diaphragm and gas under diaphragm? Same code.
Okay, I think he meant air under diaphragm dengan dengan stomach air.
Sama air.
I think that's what he meant. Macam ni, kalau misal kata air under the diaphragm, I tunjuk tadi punya ni slide tadi tu. I don't have that slide now because itu actually in the last session. Ini pun sebenarnya kan kalau ikutkan tak habis lagi kalau you nak belajar chest X-ray. Tapi I pun tak sanggup nak sambung mengajar chest X-ray sebab banyak gila. Okay, like this. I bagi contoh kita bagi comparison dengan this one. Okay. If you see this, kalau air ada the diaphragm kan for for peritoneum, you'll be able to see usually both sides.
Okay.
Nombor satu, both sides, provided the patient is already erect at least 15 minit sebelum kita ambil gambar. And then satu lagi, we can also see dekat between the stomach bubble and the diaphragm, there's another bubble.
Okay.
So macam those are the telltale signs that it is a normal ni lah. Kalau misalnya kata patient tak boleh duduk straight, then you just buat decubitus, dia punya right side up. And then right side up tu keep for about 15 minutes baru you ambil lateral shoot through. Lateral shoot through tu maksud patient ni baring macam ni. And you punya X-ray taruh sini. You punya X-ray sini, you punya film sini. You shoot macam ni. This is called a lateral shoot through. So you can see that dia punya dekat tepi liver, in between the liver and the abdominal, upper abdominal wall tu ada terkumpul air kat situ. So that's one way for you to for us to differentiate.
Sorry, Dr. Kay, I think your video tadi when you were trying to explain a bit, I don't think it was appearing on the screen. So can you repeat that again, maybe for our audience out there?
Which part? Let's shoot through. Okay. Let's shoot through. Okay. Kalau ada patient, dia tak boleh nak duduk because you cannot have you cannot have the patient to sit. Because you need to sit at least 15 minutes for the air to rise up kan. So we can still put the patient in lateral decubitus. It means that patient tu baring mengiring, bahagian badan on the right side is up. And you keep there for about 15 minutes so that the air has time to accumulate. And lateral shoot through means that the patient baring macam tu. Ni kan yang baring supine kan. Ni lateral shoot through. So this is the right side up. So the X-ray is the X-ray one part, the film kat sini, and you shoot macam ni. So when you shoot like that, if there's this is the abdominal wall, the upper abdominal wall, and this is bayangkan this is the liver, and suddenly you find that there's a gap at the air kat situ, then you can almost be confident that that's a pneumoperitoneum lah in that patient.
Okay. I think that's all from a question from the audience. So I give the floor to Dr. Hafsa.
Okay, Dr. Kay, thank you so much for your session. And this is your second session, and we're looking forward to having more sessions with you. I can see your enthusiasm, so why not? We probably lock you on certain dates from now. And I think we have our next CME Back to Basics teaching will be on the 3rd week, right? Is there any topic confirmed yet, or we're still thinking about it?
The next one will be by Mr. Mahyudin, common misinterpretation of the fracture. But I will share the poster later on. It's on the 3rd week of this month.
The 3rd week of June, and we'll update you the details on our social media platforms. Thank you everyone for joining us. So have a good evening, and Assalamualaikum.
Welcome, salam.